I'm going to introduce our speaker for this evening. So we have our own Lisa Max, one of our CNSABC board members who's presenting us today. So Lisa's a diabetes clinical nurse specialist, certified diabetes educator, who has spent 21 of her 37 years of nursing in the field of diabetes. So Lisa's role covers in and outpatient care and works at that system level to enact change. The scope of practice for advanced practice nursing includes providing expert consultations to prescribers, leading quality improvement projects, leadership, education, and research. And she also works in community health settings, specifically with family provision physicians providing diabetes care in their office, as well as support for long-term care facilities. To present to us today, her topic today is what's weight got to do with it? A review of current obesity guidelines.
Let's see if this works. I also have the privilege of working on the unceded homelands of the Coast Salish people, but I'm speaking to you today from my home, which is on the Tsawwassen First Nations, and I'm very grateful for being able to enjoy these gorgeous lands that we live on. So I want to also I know this isn't diabetes, but it's so intertwined, obesity and type 2 diabetes in particular. And there's so much new data out there that I really wanted to just share it with you. And everything I'm sharing is from the Canadian Obesity Network, grounded in research. I'm attending a lot of sessions on this because it's we finally have some data to share. And I'm actually going to be able to shadow one of the gurus in obesity management out of Toronto, Dr. David Macklin, virtually. I'm shadowing him in June through his clinic. So very excited about that. But also want to let you know that I'm not an expert in obesity. I'm going to show you what I have, but there might be some questions that I'll have to get back to you on. So we'll do the best we can there. So I want to talk about the 5 facts about obesity, because we do have a lot of myths out there. Explore the health impacts of obesity and review the science of it, and identify some strategies to reduce stigma. We have a lot of stigma with obesity. Go through the dietary and physical activity recommendations for people with obesity, how to individualize pharmacotherapy and other interventions, and address any side effects of those, and explore how to manage a patient who's reached a plateau. So let's see if this works. Okay, first fact, obesity is a chronic disease, and we haven't really thought of it in that way before. So it's not a personal failure or a lack of willpower. It is a chronic disease, so it helps remove that stigma, because you wouldn't blame somebody for having schizophrenia, for having multiple sclerosis. These are things that can be treated, but they are with the person for the remainder of their life. And we do have data to show that there are such similarities between other chronic diseases that it needs to be designated as one. Chronic diseases last a lifetime. They require ongoing care, and they are complex interactions between biological, genetic, and environmental factors. So it fits the definition. And as with any other complex chronic disease, it needs to be diagnosed by a qualified healthcare provider. And if we can define obesity and recognize its complexity, we can move away from those oversimplified narratives that blame the person. Oh, well, you're just lazy. You need some willpower. There are conflicting things that are going, I'm looking for the right word here, the science behind it, that are pushing a person into struggling with their weight. So if we look at other chronic diseases like type 2 diabetes or hypertension, they are similar. So the diseases that arise from a normal physiological process, so we're doing okay and then things tank. We have glucose regulation that is a problem in type 2 diabetes. In hypertension, we have baroreceptor, RAAS, and osmoreceptors. that impact the blood pressure. And in obesity, we have gut-brain and adipocyte interaction that senses food intake and energy expenditure and wants us to conserve it more. The physiological changes that lead to that development in type 2 diabetes, impaired insulin receptor and signaling, hypertension, we've got similar things of arterial tone, and in obesity, it's a leptin resistance or excessive accumulation of these fat reserves. And health impairment due to the physiological changes, there's impacts of these chronic diseases. And so type 2 diabetes, microvascular, macrovascular. I always say that people don't die from diabetes, they die from the complications of diabetes. In hypertension, we have cardiomyopathy, stroke, chronic kidney disease. And in obesity, we've got type 2 diabetes, cardiopulmonary impairment, GERD, dyslipidemia, obstructive sleep apnea, osteoarthritis, fatty liver, and more. So this is why it is considered a chronic disease. It's driven by biology and not always by choice. So this was an interesting stat, is that sometimes this is beyond a person's control. 70% of the risk of obesity is determined by genetics. So if you have a family history of obesity, 70% of your incidence of diabetes, I know I'm going to flip into that, obesity is from your genetic makeup. There's a brain system that's out of whack, that doesn't control our hunger properly and doesn't control our energy regulation. And so this creates a lot of biological barriers to weight loss. Obesity is characterized by abnormal excessive body fat, or also called adiposity, and that impairs health. So it's not a single body type. You can have people who are in smaller bodies but have obesity because they have central obesity. You can have people in larger bodies who have a lot of muscle tone, and so they wouldn't be considered obese. Focusing on the health measures of health rather than the appearance is what we move towards in treating people who have obesity. So we don't want to blame the individual for their weight, because and look at them and say, you need to have a different shape. We're given these shapes by our DNA, and yes, we can manipulate them to some certain degree, but that takes a lot of effort. That we know that a lot of these movie stars are in the gym for 2 and 3 hours a day in order to get in the shape that they need to, and that's not really doable for people who live a normal life. Another fact is that obesity can impact health early. So, in the growing body, if you have young children who have obesity, this can lead them to obesity later on, and it puts strain on their physical health and increased risk of conditions like type 2 diabetes and high blood pressure. But beyond the physical, it's the mental and emotional toll of living with obesity, like stigma and low self-esteem, and this can leave lasting impacts. Just the language that we use on ourselves, saying I'm bigger than somebody else, or I just need more room in this world. Those really impact the mental health there. And early prevention and management are critical to reducing these risks, because the body is always going to want to get back to its highest weight. It is going to fight there. Another fact is obesity is treatable. It is individualized and adaptable to everyone's unique body, biology, and life circumstances. And we know that one size fits all does not work. And we know some people are not in a position to be able to put all of their effort into dealing with drastic lifestyle changes that might be required to treat their obesity. And even though we've got emerging science, we have emerging treatments for obesity, there's new and more effective ways. Sometimes the success is not measured by weight loss, and perhaps by weight composition, which is where the DEXA scans come in to measure the adiposity in the body. And really, it's basically trying to improve overall health. And if that's not changing your shape whatsoever, but replacing some of the adiposity and visceral fat with muscle, then that's effective treatment. And effective evidence-based options like behavioral therapy, lifestyle adjustments, prescription medications, and surgery can all play a role. And the fifth fact is weight bias, stigma, and discrimination harm everyone. weight bias isn't just personal. It creates structural barriers that care that worsen the health and outcome of the mental well-being. About a month ago or 2 months ago, no, it would be before surgery. So my husband and I were on the SkyTrain coming back from an event that we went to downtown, and there was a woman in the handicapped seat on the SkyTrain, and this other woman got on and insisted, even though there were other seats, she insisted that she needed to be in the handicapped one. So the person who was sitting beside this larger woman got up, even though there were 5 other seats she could sit in, so that she could have her seat. And then she proceeded to berate this woman for her size and tore a strip up and down. And I just couldn't stay silent. And basically was polite but firm with her and said, "You have no right to speak to her like that." And she had some mental health issues, so of course that wasn't going to go anywhere. But I just was mortified for the treatment that she received. And even on the SkyTrain today, there was a larger fellow sitting next to me, and I kind of had to do the one cheek on and one cheek off. But it wasn't bothering me. It was, we're all going to try and fit in here together. But you can know that some people are going to make a big fuss over that. And we know that fear of judgment causes many people to avoid seeking medical help because there's stigma going to the physician, going to the nurse, the dietitian, and this can delay diagnosis and treatment. So that societal cost is steep, because when they do get diagnosed with it, they're now down the field in terms of its progression of the disease, whichever they're looking at. And really respecting people of all sizes is the first step to eliminating bias. When we have things that are just not built, I've been 5'10" from age 12, and those tiny little chairs that, the desks that I had a very small school. We had 95 kids in the whole school from kindergarten to grade 8. And we had these tiny little desks that were attached with the chair. And I'm all leg. I just didn't fit in them. And I just felt always very large in them. So it starts early with the self-talk. But really, we have nearly 1 in 3 Canadians that are affected by obesity. And despite its widespread impact, it often goes untreated, and that leads to significant personal, societal, and economic consequences. So when we fail to recognize and treat obesity as a chronic disease, it has increased our economic cost to 20% higher than previously estimated at $27.6 billion. So there really are so many conditions that are associated with obesity, and that's what I want to walk through, some of the major ones here. Mental health, first one, is that this weight stigma and bias, this can lead to depression, anxiety, disordered eating with the yo-yo dieting, low self-esteem, negative self-talk, body dissatisfaction, and it really is trying to tackle these changes is essential to providing compassionate whole person care. And the language that we use is so important that, oh, let me get you a bigger chair, or, oh, I've got to use the big blood pressure cuff on you, just wait a minute. So those sorts of things really remind a person, it's like it's in their face all the time, that they're being judged. And even if you're not meaning to judge, it feels judgy. Mechanical impacts. So it really can place extra strain on the body, and that's with obstructive sleep apnea. We have a lot of people using CPAP now. Heartburn, like GERD, osteoarthritis, plantar fasciitis, incontinence, and skin fold infections. And so it makes everyday activity challenging, and it limits their independence and significantly impacts overall quality of life. I joke that we just got a boat, and last year, at the end of last year, we bought it. And I bought one of those tubes that you pull behind, because as a kid, I always wanted to go on one of those tubes. And as the knee replacement happened, and I'm thinking, what was I thinking that I could get on an inner tube on the ocean and have have my husband pull me around? I'm like, I think I was a little out of sort there, but in my brain, I'm a 12-year-old that could handle this, but I'm actually not. So we'll see how all that goes. And really, the inaccessibility of physical spaces. I can't describe to you. There was one house that we were looking at very young in the marriage, and they had a 28-inch door. And my former partner was 6'4", and neither of us could get through the door front ways. We had to turn sideways to get into the bathroom door. It's like, talk about, for Lilliput land there, it just wasn't made for humans. The standard furniture of trying to squish in. I've just been on a plane this week and, it was fine, but I can see someone who might have been a little heavier having a real struggle because I was cheek to cheek. Healthcare equipment, there's airplanes, public seating. It really doesn't accommodate these diverse body sizes. And really, we need to address these barriers in our healthcare setting where we have control for sure. And we've advocated for larger seats, the large blood pressure cuffs in every room. So it's not I've got to run out and get the big blood pressure cuff for you. And a weigh scale, if we ever did use them, we don't use them often in the diabetes clinic, that isn't one of those ones where you put the weight, the old style ones, where, sorry, it's not big enough for you. Metabolic health, so it's really closely linked to type 2 diabetes, of course, hypertension, high cholesterol, gout, fatty liver disease, infertility, and certain types of cancer as well. And really, we've got to manage these risks, and it requires a personalized, evidence-informed care to reduce these complications, and not just weight loss. It might be weight replacement of muscle versus adiposity. And the monetary costs, the financial impact of obesity is significant. I have to buy larger clothes. I have really long legs, and I cannot buy regular clothing. I have a 34-inch inseam. And so I've always, either they were too short when I was a kid, not knowing that you could buy larger shoes or larger, longer pant legs. I was wearing, capris forever because I just didn't know that they made clothing that long. Because I'm old, right? We didn't have them then. So I have to pay more for my clothing. Or when I think of my daughter who, just traveled for 6 months in a backpack and she's much smaller, her pair of shorts and her shirt or her jacket are smaller amount of fabric, which means she can pack in a backpack. But for those of us who need a little more material to cover our body, it's not only higher cost, but also heavier weight for that as well. And it does impact higher healthcare expenses. There's costly medications and loss of productivity at work. And weight bias and discrimination just make these challenges worse. And they did, I saw one study just the other day that said that people with obesity, living with obesity and have complications, had a 70% wage earning compared to someone who was not. And they often are passed over for promotions or excluded for professional opportunities, despite their qualifications, because people see them as lazy, or I don't want you in front of the camera. So that's always a challenge. And then many of these treatments and medications that are there remain uncovered by provincial or private healthcare plans. And that puts it out of reach for many. $300 a month for Ozempic. If you're on the highest dose of Mounjaro, which is for diabetes, it's not indicated for weight loss, but it is showing it's like Ozempic on steroids. It shows 40% more weight loss and actually less side effects with it. It's at the highest dose, it's $800 a month. So that's not reachable, and it's not covered by many plans. So it's really unequal access. And then really we need to change things systemically to ensure that it's equitable and accessible for everyone. So it can impact almost every organ. I've got them all listed on the left here and the incidences on the right. So we know that we've, with BMIs greater than 30, and we're actually going more to a height-waist ratio as opposed to a BMI, because that seems to be a little bit more kind to it. So it should be 0.5. If your waist, I'm just going to use a number here. If your waist is 40 inches and your height is 80 inches, you've got a 0.5 ratio, and that's appropriate. But if your waist is 40 inches and your height is only 60 inches, your ratio is now at 0.75 or 0.7, and that's getting too high. So the science of obesity is that some are predisposed to obesity because of these inherited genes, and this impacts metabolism, appetite, and fat storage. The body cannot convert the food into energy properly, and this plays a crucial role in those disruptions in metabolic processes. So for an example, insulin resistance, that contributes to weight gain. And of course, dietary choices, particularly high caloric, nutrient poor foods and lack of physical activity, those are major contributors, but they're not the only contributors. Stress and emotional eating and sleep disturbances are very linked to obesity, and access to healthy foods, socioeconomic status, and the built environment. So do you have the ability to go for walks that are safe and you're not going to get hit by the car? These also impact obesity. But the hormones that are involved are leptin, which tells the brain to stop eating, and ghrelin, which tells the brain to eat. And insulin, of course, is in there for insulin resistance. But basically, we've got our stop eating and our start eating. And so if you can imagine that a person has got appropriate levels and triggers of the stop eating hormone leptin and the start eating hormone ghrelin, then everything works well. But when you have obesity, the start eating ghrelin hormone is the one that there's too much of it, and there's not enough of the leptin to tell us to stop eating. So there's really these hormonal imbalances that are happening in the brain that not only are they're just trying to battle through these things. And there's, of course, the energy imbalance of how many calories are in, how many do you expend in your excess expenditure of activity. And this would result in a person who has 300 extra calories that are going to be stored as fat or muscle, and the weight's going to go up in here. So there's also three controlling mechanisms for eating. And I'm going to direct you at the very end to an amazing, really good explanation of all of these mechanisms here. And the first one is the homeostatic system. So these are the eating for survival. These are, I must eat or I will not survive. And that's what our body was kind of bred to do from caveman days. It's like we didn't know when we were going to get our next meal, right? So we ate for survival. We've got triggers that will allow us to smell it or see it, and that's going to trigger the hedonic system, which is eating for pleasure. So, would I love to have the dessert that's on the table? Of course, but I'm going to choose the salad because that's what I'm trying to do for my executive function of I'm trying to make a good decision. So we have those three areas there in the homeostatic, that's for survival, the hedonic, which is for pleasure, and the cognitive, which is trying to make the decision on this. So very complex, integrated system. And the body will always respond to weight loss by trying to go back to your other weight. And that's the sad part. All these years I've been listening to talks by obesity specialists, and I'm like, there's really no hope for me, man. Because when you yo-yo diet and you go up to your highest weight and then you drop your weight, you're going to always want to battle up to the highest weight that you left off. So it's not even my 22-year-old weight. It's my, whatever year weight. So, hormonal changes with weight loss, they increase the hunger hormones. They decrease satiety hormones, which means satiety is when do I feel full? And if you're not feeling full, that's the whole premise behind GLP-1s or Ozempic and Mounjaro, is that it tells you feel full faster. So it kind of grabs onto the brain and tries to trick it a little. It makes you want to be more hungry, these hormonal changes with weight loss. You want to eat more, and you have an increased risk of weight regain. So you're trying to balance your food intake with your energy expenditure. And then we've got those thermogenic changes with weight loss. So that's the activity part of things. So the body's fighting to try to get back up to there. So in the bottom part of this, it's weight conservation is an evolutionary protective mechanisms to defend against food shortage. Are we going to get another meal? So it's beyond just eat less and exercise more, which is what we've all been told and preached at all these years. What's your problem? Just eat less. It's simple. Eat less and exercise more. It's not simple because there's a battle in the brain that's happening that you have no control over. And that's where some of the medications are coming in. So what do we do about this stigma? So when we apply these negative weight stereotypes to ourselves, we have a degree of shame or distress, and we internalize these beliefs that people with obesity are lazy, they're weak-willed, or they're lacking in self-control. So the person with obesity has self-shaming or self-blame, dissatisfaction when they look in the mirror, and anxiety about being judged for the appearance. And then there's the explicit bias, which is stereotyping, prejudice, discrimination, and weight shaming. And a study showed that 30% of healthcare providers had negative attitudes towards people with obesity in their practice. And another one found that family medicine physicians, same amount, believed that people with overweight were lazier than those who were not overweight. So the stigma is there. The negative impacts are physical. We have those increasing cortisol levels, which actually increases glucose levels, and oxidative stress, which is terrible for our blood vessels. We have higher risk of comorbidities, perceived poorer health, and higher mortality risk. And then in the mental sphere, we mentioned before, higher risk of mood or anxiety disorder, more internalized weight bias, and a negative thought of body image and chronic stress, which we know is so damaging. And the healthcare system, there are people who don't give the same level of care to someone who is heavier with their stigma, bias, and assumptions. So they get poorer quality of healthcare, delays in preventative healthcare, because perhaps they're heavy enough that they don't actually notice the lump in their abdomen, and they might not go for cancer screening. Or why are my stools off? Or I just, have this gut problem here, but you can't palpate it properly. And there are delays in that. So they avoid healthcare interactions, especially if they've had a terrible interaction in the past. And this is the same with Indigenous bias, gender bias. It all leads down to not seeking healthcare. And so some of the steps to reduce this stigma is to ask permission to discuss the weight. If the person doesn't want to talk about it, they shouldn't have to. Is it okay if we talk about your weight today? No, I'm good. I'd rather not. Move on. Be non-judgmental and acknowledge that weight management is a challenge. There was a presentation by one of my colleagues for journal rounds last month, and it was about the DIRECT trial, which showed that people who took drastic lifestyle changes could achieve remission from type 2 diabetes. And she showed a clip from a UK physician who is supposed to be an expert in obesity. And he actually said in the video, it's easy. People love it. They just eat less and exercise more. And I said, what year was that made? Thinking it's got to be from 20 years ago. And it was last year. So I was really disappointed that that is still out there. We need to explore their readiness for change. And I have a slide on that as well. Most of us know the Francesca's trans-theoretical model of change and acceptance for wanting to do something different and creating the positive space, as I mentioned before, and really avoiding magazines and pictures that can be stigmatizing. We have in the diabetes clinic, if anybody walks through, we have some posters up about obesity and saying this is a safe space for you to be. How do we reduce the stigma? Don't use terms that can worsen the stigma like fat, obese, or large size, and maybe consider using the term weight when discussing obesity. Don't make assumptions about lifestyles or behaviors or motivation. You don't know if that person in front of you goes to the gym every single day and works out and does the best that they can possibly do. And they might be more fit than you, who might not have obesity but can't get to the gym. Don't scare or guilt them. You've got to lose weight or it's going to kill you. Aren't you worried about your health? And I mentioned that the statement here that was mentioned was, losing weight's easy. Just eat less and exercise more. Not a thing to say to somebody. So should we recommend dietary and physical activity changes for people with obesity? And the short answer is yes, as long as you're treating them as an individual and respecting their intentions and abilities to attempt a healthier lifestyle, and also realizing what situation they might be in. At St. Paul's, we deal with a lot of marginalized population who struggle with appropriate housing, food intake. They're not really in a position to go to the gym, right? They're trying to struggle for survival. So we need to really take a look at the person that's in front of us. And if we can acknowledge, empathize, and normalize so that we're using this time to understand what the patient's perspective is, ask permission to work together with them, ask them what their ideas are, because they might have some great ideas and they just might need a hand figuring out how to implement them, and then ask permission to provide our ideas on the solutions. Don't just jump on, this is what you need to do. Let's work together, because that can support the change management. And this is, again, a very sad slide in that in 10 years of follow-up in this diabetes prevention program, the lifestyle arm lost a lot of weight initially, 7 kilos, and over time, gained the weight back to almost the placebo arm. So it just goes to show that it is a real struggle for people to lose the weight and keep the weight off. So we need to make sure that some of these diets, and this is what I have a problem with Ozempic, is that they're not treating the underlying problem in relationship with food. I have lots of friends on Ozempic in my ladies group here in Tsawwassen, and they're paying out of pocket for it. And I had one friend say, yeah, I haven't eaten much today. I just had a Krispy Kreme donut. And it's like, well, you're not changing your relationship to the healthy foods. I know you're not hungry, but really it's the healthy foods that should go in place of the high caloric, not good for you foods. And nutrition plans need to be flexible, person-centric, culture-centric, their shift work, availability of food, the cost, and focusing on health improvements as opposed to focusing on the weight itself. So the patient should eat the best they can in a way that's enjoyable and sustainable for long term. So some of the nutrition therapy tips are identify the triggers. Am I hungry, or is this a craving? Do I need to sit for 5 minutes and figure out whether I'm truly hungry or not? Prepare the meals at home as best you can. Eat a diet low in processed package or restaurant food. It's more expensive to eat that way anyway. Eating slowly. I struggle with that a lot because I'm so used to being a nurse that was at the bedside that had to hoof my food in before shooting off to the next thing. And so I really struggle with trying to eat slower. Avoid keeping unhealthy snacks and food in the house. And there's one program called Lifestyle RX that I'll mention later, that the first week that they have you there, it is 10 things to ditch from your kitchen. And it's just the things you should get rid of so they don't call your name. Chocolate calls my name. It's yelling at me from the cupboard if I have it in the house. Stop eating when you're no longer hungry versus when you're overly full, or taught to eat till the plate is empty, right? Monitor the calories from beverages. I realized a long time, 30 years ago, I said I'd rather eat my calories than drink them. So I stopped drinking juice altogether. And I was raised on orange juice every morning, right? Sometimes keeping a food diary and documentation can help, or on apps, calorie tracker apps, and use smaller plates if the portions are a challenge. So regular physical activity is beneficial, even if they don't lose weight. We know that. Aerobic physical activity can have small decreases in weight and fat. It can decrease the visceral fat and ectopic fat, and it favors weight maintenance, increases cardiovascular and mental health, and improves sleep, energy, and self-confidence. And the amount of weight a person can lose with exercise alone is usually relatively small. They usually need a combination of both food, dietary and exercise. And consider the context of the patient. I'm not doing a lot of activity right now after a knee replacement, right? Or if they're sedentary to start, they're not going to go and run the marathon. So we need to suggest things that are doable. So individualizing the pharmacotherapy or other interventions for that patient that it's in front of you is we need to base the choice on their values and preferences. They're not going to do anything that they don't believe in. What are their goals of therapy? What is it that you want to get out of this? Are they wanting remission from diabetes, remission from some of the comorbidities? Controlling the cravings or appetite might be their primary problem. Improving their quality of life so that they can go and get in the garden. Weight reduction and maintenance might be part of that, and the cost and accessibility of the medication. It's beyond many people's means to afford these medications. And this is from the Obesity Canada clinical pathway, the decision pathway. So it says if the patient and healthcare provider are considering obesity pharmacotherapy, we give them the information. If they have no access to meds, we're going to advocate for access. And if they have some access, we want to consider all of the agents that are out there and make a decision based on their preference, their ability to get this medication. So we start it, assess it after 3 to 6 months, and if they're not met, the goals, then we substitute another medication, and if they're met, we continue it and continue to reassess. So these are medications that are approved in Canada for weight loss, and I mentioned Mounjaro only because of it is for treatment for type 2 diabetes, but it has exactly the same properties as Ozempic, and it will likely, hopefully, get a weight loss designation independent of diabetes, just like Ozempic has. So the older one that was made by Novo Nordisk called liraglutide is once daily, and so people don't typically take that. They'll go to the semaglutide or the Ozempic because it's once weekly. Contrave is another one that is a pill. And it treats overweight and obesity. It does have some benefits with A1C and improves depression and cravings and quality of life, but costly. No provincial coverage anywhere here, right? Nothing. And Xenical, Orlistat, nasty drug. It will make their poop orange if they eat anything that it has any degree of fat in it. So it's not pleasant whatsoever, and there's a lot of leakage that happens. So there are benefits to this, but there are also costs, and we have to weigh everything. So really, we need to focus on the impact of the comorbidities and health parameters rather than the percentage or the amount of weight reduction, because people expect a certain weight loss, and they don't realize that they might not achieve that with the drug even. And of course, there's surgical interventions, gastric sleeve, Roux-en-Y gastric bypass, and biliopancreatic diversion with duodenal switch. And they used to do gastric banding, but it's less effective. It has higher rates of complications, and it doesn't impact the underlying obesity-related hormones. But we have noticed a remission from type 2 diabetes very quickly after, especially the Roux-en-Y gastric bypass. I have a friend who was 420 pounds and she's down to 170. Now, this is 8 years later. She's been meticulous with it all and really done an amazing job with that. And the comorbidities that I listed at the beginning, she had almost all of them, and all of them have reverted as well. And there are medical, I'm talking now about the type 2 diabetes remission. I just wanted to point that out. That's a little different in that some of the drugs that we use to treat diabetes also have weight loss properties. Metformin's very small amount. SGLT2 inhibitors can have a small amount. Ozempic and Mounjaro are the ones that are the big bang for your buck. And Mounjaro has been updated to an insulin pen looking device, same as Ozempic, as of like 3 months ago. So what about some of these side effects? We know that Victoza, that semaglutide all cause GI-related side effects, slower titration, avoiding high fat or spicy foods, and eating small frequent meals. and they can slow that titration and consider staying at the lower dose if they're not feeling hungry. I do find that some people are reacting more to the Ozempic than they are to the Mounjaro, which is surprising because the Mounjaro is almost a more potent drug, but time will tell. That's just anecdotally. And the Contrave or naltrexone bupropion, lots of fluids, take with food, manage the headache. I actually tried this drug about 8 or 9 years ago. I'd never experienced a migraine in my life, and I had 2 of them. One day, I only took it for 2 days, and I had 2 migraines. I empathize with all of you who suffer from migraines. It was the worst feeling ever. Didn't do well on that. And again, the orlistat, oily stools, and just not pleasant. If you like your patient, probably don't order the orlistat. And how do I manage a patient who's reached a plateau? This is what people expect. I'm going to lose 2 pounds a week, every week. And, my predictor is going to tell me on my phone that I'm going to be at this weight by this date. And what really happens is that there are these bumps in the road, and sometimes there's a full plateau where the drug just won't remove weight anymore. You've reached the threshold of it. So it really is important that the patient not rely on the drug itself and really needs to address the underlying relationship with food and activity. So it really does happen with all obesity interventions. And really need to take a look at stress and sleep medications as well. The patient will say it doesn't work anymore, so I'm going to stop taking it, and they will gain the weight right back. Or is there anything stronger? So lots of people are moving now from Ozempic to Mounjaro because their Ozempic has kind of plateaued, and now they're moving to Mounjaro. But I will say the degree of in those susceptible for Ozempic or Mounjaro of slower gastric emptying and constipation, if they have struggled with that to start with, that is not a drug to take because it'll make it a lot worse. Really frame the importance of the health goals. So not the number on the scale. Focus on how you're feeling. How are your clothes fitting? Have they reached their own goals? And focus on their best weight, on what they consider their best weight. And, my best weight is not going to be from when I was 22. Isn't going to happen. So I've got that out of my head now of that's not an achievable goal for me. And really consider changing some of the pharmacotherapy if the goals aren't being met, remembering that obesity is a chronic progressive disease. And always set the realistic expectations before and during treatment. And this is what bothers me about the Ozempic rush of the Kardashians, who basically came up and they pillaged all of our Ozempic and took it away from people with type 2 diabetes because of the shortages, the flood from the States that we had because it was 300 Canadian dollars and they were charging $1,000 US. It's about $200 US here. So they came up and really just, pillaged, and we had nothing left, which is why they set the price higher for Mounjaro to try to avoid that as well. But they didn't get any counseling on top of it. It was just, I'm going to see this blog of this person who was on Ozempic, and I'm going to take that now. But they didn't get any interventions with their relationship with food, which contributed to the issues in the first place, along with the mechanism in the brain that is off balance. And this is a really great slide on healthy behavior versus hedonistic behavior. So healthy behavior is abnormal behavior, because if it was, if you had a salad in front of you, or you had a baked Alaska, we're going to want to go to the baked Alaska. That's our hedonistic approach. The healthy behavior, if it was normal, it would be easy. It's not normal. And so, we avoid it and go, oh, how many people have said to you, it's a special occasion, you're fine, just have this and then you go back on your diet tomorrow. People don't also follow recommendations. They follow their own beliefs, and they focus on recommendations when a patient isn't ready. And that's very risky. So when the healthcare provider is not assessing their stage of readiness for change, there builds up more resistance because they walk away from that visit and say, they're trying to force me into, doing this behavior, and it makes them resist it even more. And really, our emotions do dominate our logic. We all would love to be able to choose the healthy thing every single time, but the smells, the location, you're going out for pizza and wings one night. Well, you're not going to order the salad because you've always gone for pizza and wings and beer or whatever it is. And, we're with our friends and that sort of thing. So I mentioned that executive system and the hedonic system. So there is a reason why there's a whole, what are those called? All-inclusives called hedonism, right? Or is it called hedonism? We'll have to talk about that after. But, it's do whatever you want to do. This is the place to let go. I'm on vacation. It's our tendency to want to do the fun stuff. So really, ambivalence is normal. And if a behavior was natural, we'd be doing it already. And behavior change is about doing things that don't come naturally. We're fighting that hedonistic desire that we have. So we need to expect the barriers. And then the Prochaska's trans-theoretical model of change that many of us use in our practice, really just want to point out that the cycle here, pre-contemplation, is that you are not thinking about making a change in at least the next 6 months. It's like, not ready. Contemplation is, yeah, I know I've got a problem. I need to do something about it. And I think I might want to start prepping for that. And the preparation is, of course, saying, okay, this is the date I'm going to do it. I got my exercise bike out. I'm going to go out and do my walk. Like, planning it and making it happen is action. And then maintaining that is, I'm starting to feel like, this is something that's part of my life. But relapse is part and parcel of this, is that we can all sustain really good behaviors for 3 months. I can diet like there's no tomorrow for 3 months and be perfect. But after 3 months becomes a real challenge when you make a drastic lifestyle change. Relapse is normal. It's not a failure. It's just a relapse. And we can go right from relapse into preparation and action again. And then hopefully we get into a stage which isn't listed on here, but is called identification. So that to me is the juice. The orange juice I stopped drinking 30 years ago, I don't even care about juice. So I identify with that behavior change, that it really is of zero interest to me. Not everything's going to come to that way. We could go for 2 years doing amazing, and then something pulls us off the treadmill and we've got to get back on again. That's the identification one. So I just wanted to point out some resources for apps and websites. Diabetes Canada's got an amazing one. The Obesity Network as well is a really good site to go to. And I mentioned before this Lifestyle RX, and if you haven't heard of that, it's a physician and dietitian-led 12-week program that's under BC, Alberta, and Ontario pharmacare plans. It is free for people who have type 2 diabetes, and it's just been expanded into the metabolic syndrome. So people with obesity, people in pre-diabetes, it is a free program. It's interactive online. So I actually did this program to proctor it for Providence Health, and it really did amazing things for me in changing my attitude towards food. I went every week on a 1-hour group visit. I had blood work done at the beginning and the end of the program, and it was analyzed and discussed with the physician at the beginning and the end to see where the issues were. And then the dietitian was available at every week as well for us to ask questions of them. So if a person's in the right stage of readiness for change, that is an excellent thing to send them to if they're ready. If they're not ready, don't bother, because it is there's a lot of things that are suggested that you can't implement every week. So it really took me about a year to implement all the things that they suggested, because you're only able to catch up and keep up with a few at a time, right? Noom is a great program. Any of the Calorie Counter or Weight Watcher apps, Plate Joy, you take a picture of your food and it tells you the composition of it. Another one's called Chronometer, MyNet Diary. MyFitnessPal is really good for fitness, and Fitbit and Strides. And then this was, again, the Lifestyle RX program that I just mentioned. And I do believe they have a maintenance program as well now. And now this is what I wanted to finish off with, is that the Dr. David Macklin, who is really good at explaining obesity and has been doing it for his entire career. He's a family physician, but specializes in obesity medicine. And this is a 9-minute and 43-second video on explaining the pathophysiology and the science of obesity. So if you get a chance to look at that, he makes it really simple to understand what our brain is fighting in order to get through this. And those slides are available. I've given my slides to Karen, and I think she's even got them populated already in the minutes. So the key learning points are that obesity is a chronic disease, and it's complex, and it requires lifelong interventions to reach the treatment goals, and you're never finished. It's to me, I equate this like alcoholism. In a person who has alcoholism, they can avoid alcohol altogether. They cannot ever drink alcohol. You can't avoid food. So you have to change your relationship with food. And that's the challenge, is that you can't just say, I'm not going to eat anymore. So it's in our face all the time. The triggers that are out there, the ads that we've got, the smells, the places we drive by, and it's like, oh, I'd just really like to go there. And obesity-related stigma and bias are common, and hopefully they're getting better. But with sessions like these, I'm hoping to raise the awareness of the stigma and bias, and it really does negatively impact the person with obesity. And although we've got long-term effects on weight from nutrition and physical activity, they're generally small, the quality of life and health benefits are significant. So you're not going to lose a lot of weight just from doing physical activity, but they are really beneficial in the long run. We need to customize the therapy based on their goals and medication factors, whether they have contraindications or there's cost implications. And obesity pharmacotherapy or surgical interventions should be individualized based on the patient. I would have to be in a very severe position for me to agree to go for gastric bypass, because there's a lot of complications that can come out of that, and long-term issues. But should I be in that situation and I need that degree of help, then yes, I would consider it. But it would not be something I'd do just to lose 20 or 30 pounds. Adverse effects can be prevented and managed with education and small interventions, and a weight plateau is common and expected. So we really need to educate around obesity as a chronic disease and set those expectations and reassess the treatment goals.
Thank you for joining us. If you would like to learn more about our association, please visit our website at www.cnsabc.ca or follow us on Twitter at CNSABC.